Hello, everyone. Thanks so much for joining this morning and this afternoon and this evening in different countries in the world. It's great to have you on board for this webinar, the second in our series around PLA. I think we'll get started now. Some people may join as we go along, and hopefully they'll catch up with us. So again, thanks for joining. It's great to see so many friendly faces and also so many new people joining too. We have about 50 people registered for the webinar, and we're hoping to see many of them today. I'm Mikey Rosato, CEO of Women and Children First, and your moderator today. Just a bit of background, this webinar forms part of an ongoing PLA series that started at the end of 2020 with a session on the state of the art of PLA and a look into what the future might hold. This series will continue later this year with webinars every quarter in June, September, and December, exploring some more of the big questions facing PLA today. As you can see, in June 2021, we already have another webinar planned, which will explore avenues to adapt PLA beyond maternal and newborn health. There's so much innovation going on out there amongst the partner group, with people looking at PLA for diabetes, others looking at PLA for childhood injuries, still others looking at PLA for gender-based violence. And that's just naming just a few. So lots of exciting webinars upcoming. We also have some discussions ongoing for the September and December webinars, and so we'll send more details on those soon. But what bigger question to start with than how to scale up PLA? Unsurprisingly, this was the most popular choice when we polled participants at the last webinar to see what they might like to cover next. And of course it is. We all know that Participatory Learning and Action, PLA, has huge potential. The evidence base, built by a network of incredible partners, is rigorous and extensive. I won't present any more on this here, as I can see that a number of you already know this evidence base in detail. However, please feel free to reach out if you want any more information. And also, please feel free to visit the library in the community of practice, which houses most of the literature published and also project reports and films on the PLA approach. In addition to the evidence base, we know PLA is recommended by the World Health Organization, particularly to reduce maternal and newborn mortality in rural settings with high mortality rates where access to services is low. And still more, we know that at scale, PLA could save as many as 500,000 lives a year. So getting PLA to scale is clearly the next step and is occupying the waking and sleeping thoughts, I'm sure, of many of the partners here today and other partners working on PLA out there in the community. What is clear is that the next step is not simple or automatic. Evidence, recommendations, and potential are not enough to get interventions to scale. We wish that it was. And that is why we're here today. This webinar will explore what else is needed to get PLA to scale, and we'll draw on real-world examples of what is and isn't working already out there. I'm going to kick off with a short summary on the scale-up literature, focusing on the key lessons learned about what is needed to get interventions to scale. Then we're going to hear from Rajkumar, team leader at Ekjut, who will talk us through the experience of scaling up PLA through community health worker structures, the ASHA system in Jharkhand. And finally, we'll hear from Joanna Drazdzewska, head of programs at Women and Children First, who will present a pilot project looking at the feasibility, accessibility, and acceptability of scaling PLA through social markets in Ethiopia. But we'd love to hear from you too. So if you have any questions, please put them in the Q&A box, which you have available to you, and we will return to them at the end of the panel presentations. We also want to hear your own experiences and learn from you, so please feel free to share those too using the Q&A box. We're all friends here, so please don't be shy. There is also a chat box available, so please use this if you'd like to interact with each other directly or to raise any technical issues regarding hearing, seeing, or communicating with us. Annie is on hand to support if she can. Before we start, I just wanted to mention the PLA community of practice and how this webinar and the webinar series fits into that. The quarterly webinar series is a core component of the new PLA community of practice, which was launched earlier this month, alongside PLA news, PLA forums, and then a library of PLA resources. We are hoping that the PLA community of practice can grow into a place for all those interested in PLA design, implementation, and evaluation to come together to share and learn and collectively build the knowledge base around PLA to ensure it can achieve its potential, reaching all those who could benefit most from it. The community of practice belongs to everyone interested in PLA, so please do join if you haven't done so already, and please do share with anyone else you think might be interested. We look forward to seeing you all there. I think that's all before we start, unless anything's come up that we need to address now.
Oh, go ahead, Mikey.
Brilliant, thank you. So I'm going to kick off with a little bit about the sort of a brief summary of the scale-up literature. And the first thing I think to say is that actually there's no generally accepted definition of what scaling is. But it seems that in public health, most commonly, it refers simply to an ambition or process of expanding the coverage of a health intervention. I found one general definition, and I thought it might be useful to frame discussions today. And this is, scaling up is a process of expanding and sustaining PLA in geographical space over time to reach a greater number of people. Perhaps what is most interesting is a focus here on expansion geographically and over time and to reach a greater number of people. Scale requires expansion in all of these dimensions. Secondly, another interesting thing from this definition is that expansion without sustainability isn't really scale up. And both of those things, expanding in space, time, and to a greater number of people, needs to be done sustainably for it to be true scale up. So with that definition in mind, I looked through the literature, and to be honest, there are a lot of lessons out there about how to scale up, what works and what doesn't work. And so what I've done is try to identify the top 10, the 10 which seem to be most relevant to PLA, and which I hope will resonate with you all as you consider taking PLA to scale yourselves. The first lesson is that there is no substitute for markets or governments to deliver sustainably and at scale. Commercial markets are the world's most cost-effective, cost-efficient scaling mechanism, but they aren't right for everything or for everybody. The only other institution able to fund and deliver most goods and services sustainably at scale is government, which almost always plays a role either directly or indirectly in facilitating access by at-risk populations. And that's why we're so lucky today to have two speakers from two different PLA partners who are using two different platforms to scale, a market platform and a government platform. It'll be great to hear from them soon. The second lesson is that the more you can simplify an approach without losing the basis for its effectiveness, the more feasible it is to scale up. But we all know about the dangers of oversimplification too. I'm sure if we did a poll of the partners who've joined this call today, a large number would be able to share stories of donors or partners saying, oh, you know what, give us the picture cards and we'll take it to scale. But clearly, PLA as a complex intervention is much more than the picture cards or the sum of its other parts. And finding the balance between simplifying the model to make it attractive and ensuring fidelity to the model is what is key. And that's a key challenge. Third, scaling efforts routinely underestimate the significance of social, political, cultural, and economic context. Especially where scaling involves transferring responsibility to governments, it is highly dependent on the particularities in specific localities, states, and countries. One model for scale-up will not be effective across countries or even across all settings in the same country. That is why PLA partners are busy developing a menu of scale-up options. Community health worker structures are likely to be the primary option in most settings, and that is where most partners have focused their attention. But these structures can be overburdened or indeed or non-existent in other settings. And that's where other systems might be needed, at least in the short term. One potential alternative system is to engage volunteers supervised by community health workers. This alleviates some of the burden and has already been shown to be effective in some settings. Similarly, private providers have platforms in place that have greater coverage in government systems in some specific settings. So some partners have been exploring the feasibility of scaling up through social markets, and you'll hear from Joe about this. And in still other settings, high radio coverage, coupled with transient or permanent restrictions on movement, offer the potential for remote facilitation of groups. Again, some partners are exploring the feasibility of this model. And this is just to name a few of these options. The list is still expanding and continuing to provide many alternatives where they are needed, so that the right system for scale-up is available to the specific context that needs it. Fourth, there's a need for support for investment in intermediary organizations with the skills and mandate to help organizations scale up successfully. A number of partners are moving into this intermediary role already. And by intermediary role, we mean the role of being the small cog, which operates between the PLA approach and methodology and the large wheels, which hold the platforms to deliver at scale. Women and Children First is one such organization, and we have developed a comprehensive TA, technical assistance package, covering the design, implementation, and evaluation of PLA. The package of training and backstopping is available to anyone who wants to scale up PLA. And we can also now offer it through face-to-face training and support, and online training and support, and also now via e-learning, and also through blended learning channels. I hope we'll hear more from Rajkumar today about Ekjut's approach to intermediation in the state of Jharkhand, and I'm sure other partners will have their own examples to share. Fifth, if planners and implementers are intent on reaching scale, they need to begin with an eye on scale and a strategy for achieving it. Historically, this has not always been the case, and this may help to explain some of the challenges in scaling up PLA. However, we should take heart that there are plenty of examples in the literature where this was missed at the beginning, but corrected successfully later on. Sixth, the chances of taking innovation to scale are substantially increased by establishing mechanisms to promote early buy-in from key decision makers and potential adopters. It is hoped that the newly launched community of practice may play a role here, supporting the ongoing local advocacy efforts being led by PLA partners in country, with international efforts coordinating advocacy between multiple partners seeking to scale up PLA. Seventh, data on effectiveness is necessary, but usually not sufficient to achieve scale. Furthermore, it is important that the information provided is demand-driven and interesting in terms of content, style, and format. The need for diverse evidence explains why the PLA evidence base is as broad as it is, covering effectiveness, cost effectiveness, equity, sustainability, scalability, and many more. The strength of the network of PLA partners is the balance between research and implementation. This has allowed the network to fill gaps in information where they have arisen and continue to provide new evidence where it is needed. For example, already this year, Bansi Moldy and her colleagues at the Institute for Fiscal Studies have published a fascinating new article on the impact of PLA on consumption smoothing in Malawi. You can find out more about this in the Community of Practice library, as well as many other published articles on the evidence around PLA. Eighth, for sustainable change to occur, it is essential to replicate or substitute for the incentives that contributed to the original success of the model. It will be particularly interesting when we listen to Rajkumar and Joe to see how their models of scale-up have tackled this challenge in different ways. Ninth, the average time for scaling up a successful pilot to national application is 15 years, and we really need to educate funders and partners on the realities of scale-up. What's good to know is that the network of PLA partners is on track here. Indeed, the oldest partners have been working on PLA for about 15 years now. However, the need for patience is complicated in a policy and donor environment which increasingly prioritize innovation. Again, it will be interesting to hear if Rajkumar or Joe can shed any light on how they managed to get attention on PLA in this environment. And finally, 10th, the transition onto large, sustainable delivery platforms requires countless adjustments and accommodations, many of which are not initially apparent. Again, hopefully the community of practice will be somewhere for PLA partners to share individual and institutional knowledge on PLA, build in a resource for others to learn, adapt, and succeed with their PLA scale-up efforts. I hope this provides you with a few things to keep in mind as we now go on to listen to Rajkumar and Joe talk about their real-world experiences of scaling PLA. These 10 points are not the only things to keep in mind, not the only lessons learned from scale-up, but I think are quite instructive and certainly resonated with me as I thought about the challenges and opportunities in scaling up PLA. Now I want to hand over to Rajkumar first. Rajkumar will be speaking about scaling up PLA through accredited social health activists, or ASHAs, in the state of Jharkhand in India. Just a reminder, please do use the Q&A and chat boxes if you have any questions to ask, or you want to share any experiences or interact with each other. Once Rajkumar and Joe have finished with their presentations, we'll come back together, hopefully to answer and react to as many of these as possible. So without any further ado, Rajkumar, over to you.
So thank you, Mikey, for the brilliant introduction to scale up and key 10 lessons to be kept in mind while taking PLA or any intervention, and mostly at PLA at scale. really loved the points like government or market buying or simplicity, or the last point, devil in the detail. I will first share my presentation. I'm just sharing it. Is my screen visible?
Yes, it is. Go ahead, Rajkumar.
Okay. So during this presentation, there are two parts. In one part, I'll be sharing some experiences of evidence generation. I understand that amongst the participants, they have a good idea of the evidence around PLA, but as we kept on, creating evidence and proving the proven things again and again through this approach. So some light on those evidences, and then actual experience what happened in the scaling up. I'll take a couple of minutes to describe our organization, the organization I work for last 15 years. It's Ekjut. Ekjut was its inception was in 2002, and the major aim is to building healthier communities, and we are working towards that. And if you see the literally meaning of Ekjut, the Ekjut means togetherness in several Indian languages. And our focus of our work has been to the marginalized areas of India, and the areas or the districts of which are underserved. And right now I am speaking from the eastern part of India. The state is Jharkhand and the place is Ranchi. In last around 2 decades, 18 years of Ekjut's journey, we have reached at some point 100,000 villages where PLA was happening, and over 40,000 health workers were trained. And the themes in which Ekjut is working is maternal and child health, nutrition, adolescent health, violence against women, and in almost all these works, PLA is one strand of work. Whys are very important. Actually what keeps us going is the high mortality. I'm not coming to each of these the statistics, but the mortality is high, morbidity is high. Even if you talk about other issues like undernutrition is high, and if you see like if you just see one data that 7,000 neonatal deaths happens daily, and majority of these deaths, over two-thirds of these deaths are preventable, and which is one area where the community capacity building process through participatory learning action really helps. And if you see in India, there are areas of disparity. You can see two maps where red shaded areas are areas with most need, and in some of these areas we are working. Coming back to participatory learning and action, it's a 4-phased cycle, and in each of these 4 phases, there are a number of meetings. The first phase we call it the phase of identifying problems by community members. In the second phase, community members plan strategies based on their local resources and networks they build. The third phase is they act together. They act together and employ these strategies, and usually the third phase is quite a little longer than others. And in the fourth phase, community members, they evaluate their successes and the areas where they need more emphasis by themselves. So this is the 4-phase cycle, many people know. And the mode of delivery is not top down, something like one person tells to other person, or not didactic. Rather, it's a circular thing. It's participatory, uh, and trained facilitators enable this process. In one sentence, we can say that the community members themselves are the planners, designers, and implementers of this process. I was talking about evidence generation by Ekjut. Just see this diagram, the yellow shaded boxes, and the boxes below the line from 2002 to 2005 to 2019-20. So Ekjut has done a number of works, number of trials on maternal newborn child health issue using PLA as one strand or the main strand. And then also we try to apply PLA, the process of PLA in addressing undernutrition and some other issues. So a series of works has been done. The work has been published in high impact medical journals and media, and we try to influence the governance through this approach. And when I will be talking about scaling up, I will be talking mainly from 2016 onwards. But when government started taking at this approach at large scale, and I will be taking example from Jharkhand, the state of Jharkhand. Prior to that, I will talk quickly about two trials. The first trial, it was the Ekjut trial, where monthly participatory meetings were happening in the villages, and the results were amazing. Due to these meetings, there was 32% reduction in newborn mortality rate in the intervention areas compared to control areas. And it was published in the Lancet. We also had seen that there was 57% decline in moderate postnatal depression. So this was published in the Lancet in 2010, and this work also bagged the Trial of the Year award by the prestigious Society of Clinical Trial. Later, after some more trials, the work of participatory learning and action was recommended globally in high mortality setting by WHO, followed by the recommendation by Government of India in 10 high burden states of India. I will talk little about another followed up trial on the same process. Participatory learning and action meetings were employed, but this time the facilitators were the ASHA workers. ASHA workers are the frontline workers, and they are called accredited social health activists. So they in term is also the bridge between community and system, and they also played some activist role, but largely they are in the service delivery. When ASHA workers did this participatory learning and action meetings, apart from their continued and regular works, there was 31% reduction in newborn mortality rate. And there was a big difference from the earlier trial. This result was there in 2 years' time. The Ekjut trial was for 3 years. And this is called Johar trial, Jharkhand Odisha Health Action Research, published by the Lancet Global. So apart from the so if you just collate some of the publications and the media coverages and awards and recognitions of these things, so the work of PLA was really been attracted by the policymakers and media houses. So we published a number of the Lancet or the BMC Public Health, Lancet Global Health, International Journal of Epidemiology, WHO Bulletin. These kind of journals published the work around PLA. Then magazines like the Guardian or the Time magazine or the Outlook in India or the Hindu, these organizations also published. And we also looked for electronic media where mainstream credible electronic media has covered the participatory learning and action process. So during this time, we could find out three different kinds of scaling up or scaling up approaches. One was a health workers based model where government supported health workers are taking this work further in their respective villages. The second model, which was employed in other state, this is the government health workers as well as the combination of non-government agencies. Together, how can they take this approach? And third is government, international non-government organization and national organizations can take this. I'll be talking more on the health workers model, which was employed in Jharkhand. So when the the question of scale up came, there were different challenges, and like Mikey said, it's almost when we talk about scale, new challenges, new things come, and the first challenge amongst us was how to reach women in 32,000 villages and 40,000 ASA workers who are frontline service providers in Jharkhand. This is a huge number. And that again through this proven intervention of participatory learning action to save mothers and newborn. So in smaller areas, these things are easier, but when we go to scale, first challenge comes how to operationalize these things. And here we took this challenge together with many other partners and supporters and started working with National Health System Resource Center in India and Government of Jharkhand and come up with some innovative models. And first, the first model was how to, and the first model came as we call it odd and even approach of training all the ASHA workers. So I'll just show a few diagrams. Like if you see in the diagram, the centermost person in the red circle is the ASHA facilitator, and the others are ASHA workers. So as a governance system, every ASHA facilitator facilitates or looks after the work of 20 ASHAs. And the ASHA facilitator is one amongst these ASHAs. So we decided that instead of training 40,000 ASHAs, can we train 2,200 ASHA facilitators, and they in turn will train ASHAs, and this process will go. So this innovative model came. So Ekjut and the National Health Mission's trained ASHA facilitator. Then these ASHA facilitators, trained ASHA facilitator go to each village. First they numbered all the ASHAs of their catchment area from 1 to 20, but if 20 was the number. And then first they go to odd numbered ASHAs village, and they conduct PLA meetings. In those meetings, ASHA from the neighboring village come and listen and see the meeting and discuss with ASHA facilitator and learn the meeting. And then they return back to their own villages and they conduct the PLA meeting. They learned in, by seeing the meetings. In the next month, the ASHA facilitator goes to the village of even number ASHAs, and the odd number ASHAs were going to see the meetings when ASHA facilitator was conducting these meetings. They learn these meetings from there. They return back to their own villages and conduct these meetings. So by training 2,200 ASHAs, they were able to provide on-job training to rest of roughly 40,000 ASHAs, 38,000 ASHAs. And in 2 months' time, they were also visiting all the villages in the catchment area. And there were clear benefits, like you can see here in the right side, where 2,200 ASHAs were trained. If you see in the right side box, and we used 300 state and national trainers, and they in turn trained 40,000 ASHAs, and currently all the ASHAs are doing meetings. Every month they are trained and they are doing meetings. And the interesting part, if you see in the box, in the red box, 530,000 residential training days were saved. So when Mikey was talking about the simplicity, so the process of training was simplified, yet the rigor was maintained, and all the ASHAs were trained in turn. So this really helped the scaling up. Second, one of the biggest lesson we learned was developing commonality of understanding amongst all the stakeholders, so all the persons or the institutions who are engaged in this kind of work. So we disseminated the information. We organized meetings at community level, block with the sub-district level, or the district level, or the state and national and global levels. So at different forums, different materials were prepared and many presentations were made so that everybody is at same place. When you talk about the state level, these meetings are organized at community level. but they really need support from block and district levels, where all the incentives and support system is provided. If the state's node is there. So if you see the principal secretary, who is the head of the state health department, or the mission director, who is the head of national health mission, so they are all aligned with the process. And at the community level, ASHA and ASA facilitators were aligned, and in between all the support system were aligned. So so bringing all stakeholders together, which drives and ensures effective program outcomes, was done. Third innovation is the use of a very interactive participatory learning and action dashboard. And in this dashboard, the progress of the meeting can be seen from by anybody who has been given access, and these access were given to the block and district and the state authorities. So ASHA workers were given a very simple form where participation related details were being filled up, and these meetings were and these data were generating in the dashboard, and we were able to see, not only we were, but even people from health system were able to see what are the areas where they need more attention, which are the districts which they need attentions. And this dashboard was a unique combination of MIS and GIS features. So even maps can be generated, and different layers were created. When I'm talking about layers, means progress can be seen as per sub-district level, or health sub-center level, or a panchayat level. So all these are different administrative units, and these possibilities were created. So every month, or on a day-to-day basis or week basis, one can see what's the progress, which are the areas which needs more attention, etc. So these were the key things, and this slide I have taken from Dr. Prost, and I have also added some points. So what were the enablers? So sir, you might ask what were the challenges. We can also discuss about challenges, but as an organization, we focus more on positives. So first thing I would say, involvement of all levels of health cadre in the state in planning and implementation process really helped this scale. The rationalization of ASHA catchment areas for PLA was another work which was done when I was talking about dashboard. So when I was talking about ASA facilitator, one ASA facilitator has 20 ASAs. When we started this work, there were some facilitators who were covering 50 ASAs, and some were 10. So a huge exercise was taken by state government, and this workload and catchment area was rationalized so that ASHA facilitators are not overworked. Then the unique on-the-job odd-even system, which really helped in reducing the training cost, as well as the fast and the implementation. So in 2 months' time, these programs can be started after training as a facilitator. Timely payment of incentives was another key thing. State government really took cognizance, and almost all the payments were released timely after a couple of years. And the support from district level coordinators. We had one person to support this process in each district. And sometimes at teething stage, this support was really crucial. Another fact was the meetings were being organized in local languages and dialects. In the state of Jharkhand, roughly 30 dialects were being used while conducting these meetings. And last but not the least, the frontline workers see this as enabling for their other works. So every time we talk about, and it's right also that frontline workers are overworked. But if we are able to come up with something really unique and interesting, which help the frontline workers in their other works, they will never find it as a burden. And if the meetings are interesting, they will take it up. So these are some of the lessons we come up from Jharkhand Scale Up. And I will add one thing, that large-scale studies was also being conducted to test whether this intervention at scale works or not. It covered roughly 50,000 sample size. The paper is under publication, so I will not be able to discuss the results, but the results are very good. So with this, I will show some of the glimpses from the field, how these meetings are happening, being conducted by ASHA workers, and what is the progress till date, where 670,000 meetings have already happened in the state, and a lot more. And this process is continuing, and this has almost become a new norm in Jharkhand, state of Jharkhand, and some other states in India are also interested. Thank you very much. I'll be happy to share more during question and answer session.
Fantastic. Thanks, Rajkumar. As always, it's just amazing to hear from Ekjut. You really are at the cutting edge and the forefront of scale for PLA, as you have been at developing the evidence base around PLA as well. So it's always wonderful to hear from you, and how much I think I know about what you're doing. Every time I speak to you, I learn much, much more because you're doing so much. I think 2 or 3 things that really stuck out from what you said, and I'm not going to go through everything. I've written a long list, but 2 or 3 things that really stuck out for me. One was the challenge you undertook to operationalize the system at scale, and the lack of fear you had, or the confidence you had to innovate. So I think the odd even training system, that cascade training system, the fact that it can save 530,000 residential days, and you can imagine what cost implication that would have, is fascinating. And I think that really falls under one of those 10 points I made, which is about planning backwards. It's identifying how we're going to get to scale and not being frightened to come up with new ways of doing that. The other thing that really stuck out for me was the PLA dashboard. Again, the ability to track real-time data on a few simple metrics, which allows you to keep prototyping and innovating around PLA as it goes forward. PLA is not a static approach; it can change constantly, and I think having that sort of data coming through at all levels is clearly going to add value and enable program management. Another thing that really, again, speaks to one of those 10 learning points I made around beginning advocacy and ownership early was the fact that you involved such a wide range of stakeholders from different levels right from the beginning of the planning, not even waiting later till implementation starts, but right from the beginning of planning the scale up. And the fact that they stretch from the block level to the sub-district level, always all the way up to the global level, and coordinating, corralling all of those points of view to make sure that there was ownership from the very beginning is hugely instructive and very important for all of us as we look to scale. And the last one I want to mention now, and I'll mention some more at the end, was really seminal for us as well in our understanding, is that PLA is not an additional activity for community health workers. Community health workers are expected to be doing some form of demand generation or community mobilization anyway. And the PLA may look like it adds workload, but when people start using it, they realize actually it reduces the workload because they're suddenly able to engage with a broader number of people at one time, rather than having to go door to door to people's houses to solve problems. And the community starts solving their own problems without the need for their support. And this idea that it can reduce workload is hugely important, and something that I know a lot of our partners are thinking about very actively at the moment. But thank you very much. I'm going to just share again my screen. Rajkumar, if you could stop the share, and I'll quickly share my screen a second. Thank you. So we've already had some really good questions coming in. I've written a few down as well that we've received through email and through chat, and also through the Q&A box. Please keep sending your questions in. I'm sure there are plenty on what Rajkumar mentioned just now. Before we go on to answer them in detail, I want to hand over to Jo, who is the head of programs at Women and Children First. And Jo's going to speak about scaling up PLA through the social franchise system, or a family planning social franchise system run by Marie Stopes International, now Marie Stopes Reproductive Choices in Amhara district in Ethiopia. So this is a completely different route to scale. We now looked at the community health worker route, the government supported route, and now this is a private or a social market route to scale. So it'll be fascinating to see the differences here. Again, please, if you have any questions on what Rajkumar has already talked about or what Jo is going to speak about now, please feel free to send them, and we'll return at the end for some Q&A and some discussion with the panelists. So Jo, over to you.
Thanks so much, Mikey. Thank you also to Rajkumar for this the great presentation. I will speak about the latest innovation Women and Children First is doing around trying to scale up through a market-based approach. So to begin with, as Rajkumar has shown, it's absolutely possible to scale up PLA through government, but we know in some places the government system is not quite ready to take this on. So in these situations, scaling through the market is a very viable option. So in the context of scaling PLA through markets, I'm going to focus on social enterprises as the market. And by that, I mean enterprises that have a social mission. And you're all very familiar with examples of social enterprises that work in health. These include organizations such as PSI, Living Goods, and MSI, Reproductive Choices. All of them work through markets, but with the ultimate goal of improving health of communities. So I will start by speaking about some of the opportunities that come with this approach that WCF has considered before working with MSI. So first of all, it's the structure that they come with. Social enterprise businesses often have been around for many years. They have an existing good relationship with government, and local community respects them. And they fill in an important gap, helping overstretched health services. Furthermore, it's their human resources. So Rajkumar has mentioned the important role the ashes have been playing, and the ashes are so well known around the world as examples of community health workers. That's not always the case in all places. So this is where the social enterprises can come, because they often will have an existing cadre of community agents who are well placed to become PLA group facilitators. Furthermore, there is the flexibility of social enterprises. Often they will be better placed than public health providers to test and roll out new interventions, like the one we're currently doing with Marie Stopes. So all in all, this certainly can be a win-win. PLA allows the enterprise to build more demand for their services while benefiting communities with improved access to healthcare. And this all brings us to the important point of sustainability. Costs of including PLA are low, and once set up in an area, they shouldn't require additional funding on top of the existing budget of the social enterprise, which we know is critical for sustainability. So with all these great opportunities, there certainly come some challenges that we had to consider. First of all, to start with is due diligence. We all know with any sort of partnership, both partners need to undertake due diligence. And with certain established social enterprises, such as the ones that I've mentioned at the start, we feel fairly confident, they're there for the social benefit and respecting all of the rules. However, when considering working with new social enterprises in areas where the private sector is not well regulated and the business is quite young, due diligence is even more important. And finally, what we've also come across is the importance of understanding the operating context of the social enterprise. Potentially, there are more complexities and nuances that need to be taken into account when embarking on PLA with a social enterprise, as opposed to if it was working with the public health system. Furthermore, it's also something that Mikey mentioned is the fidelity of the model. The model was designed working through the public health system. And we realize there are some differences when working with a private company. And here, particularly where it applies to PLA, is that financial motivation undoubtedly plays a role in the work of the community agents who mobilize for the use of services. However, they will, as such, they will come with some expertise around how to mobilize communities. They will have a lot of answers to the questions communities they have. But their role as PLA group facilitators is to facilitate group. They don't provide the answers. So we need to ensure that the agents taking on the role as facilitators don't offer the answers to communities and allow them the time to discuss their solutions and to make their own decisions. Because ultimately, again, as Rajkumar says, PLA is all about the communities being in control. So it's a little bit of a method shift for expert community agents. So with this little introduction, to start with, I would like to speak a little bit about what are we doing in practice, which is the pilot with MSI Reproductive Choices in Ethiopia. So as you will all know, MSI Reproductive Choices are experts in quality sexual reproductive health provision, and with growing interest in improving demand for their services. So we are currently piloting an adapted PLA for SRH, which is PLA for Sexual Reproductive Health model, in 60 groups across the Amhara region, covering a population of 30,000. The role of PLA group facilitators has been taken on by the existing MSI family planning promoters. We are working very closely with the Ethiopia country office and the UK headquarters to support future embedding of the approach in MSI internationally. And going back to what Mikey said in his list of what helps scale up is that WCF here is acting as this specialist intermediary. We're the small cog, which hopefully will help such a large organization like MSI to take on an evidence-based approach to reach their targets. So now I'll speak a bit about the adaptations which both Rajkumar and Mikey mentioned that are important when considering scale through different models. So this project required an innovation, as off-the-shelf PLA would not work. To begin with, we looked at the focus of MSI. They're predominantly focused on improving sexual and reproductive health. So the project outcomes had to reflect that. SRH is understandably a more sensitive topic than the traditional PLA focus on maternal and newborn health. In addition, based on local sexual reproductive health characteristics, the project has to reach specific target groups that are more likely to be excluded from accessing the services. Again, the design had to take this into consideration. So how do we go about this? Well, we expanded the theme of the groups. So the theme now is women achieving their potential. So they're not explicitly focusing on reproductive health. Each meeting is designed to look at a different problem holding women back, uncovering how important good sexual reproductive health is for women and their communities to prosper. Expanding the theme outside of strictly reproductive health also allows us to discreetly focus on different target groups, such as adolescent girls and newly married young women who traditionally would not be considered as needing to be part of discussions around sexual reproductive health. The second area we had to focus in terms of considering adaptation was the geographic focus of the partner. In this case, their main focus is the areas around their social franchise clinics through which MSI operates. And traditionally, as Rajkumar has shown you, groups would saturate an administrative area. Those areas would usually be characterized by high poverty levels and a rural location. In this adaptation, another criterion was for PLA groups to have access to social franchise clinic services. They had to be based in their catchment areas. There was little point from the perspective of MSI's business model to have a group that would ultimately not be able to access their services, even though of course there would be a social good coming out of this, that is slightly on top of the core interest of Marie Stopes. So this meant communities had to be very carefully selected to meet all of the criteria. And we were able to do this by working both with the MSI Ethiopia team, the family promoters, the family planning promoters they have, and the government health extension workers who all together know their communities best. And furthermore, we also had to look at the specific interest of the family planning promoters and the social franchise clinics. And this sort of essentially is increasing the use of their services. The family planning promoters Their funding is linked to the referrals they make. And of course, social franchise clinics as private enterprises, they also want to have more clients using their services. So traditionally, PLA groups would start implementing solutions to overcome barriers to health a few months into their meetings. As you may remember, the graph that Rajkumar has shown. This means we wouldn't see an increase in service use until those solutions are put in place. For the benefit of the family planning promoter who facilitates the groups and the franchise clinics, this had to be adapted, and we adapted it through working with the groups as capsules, through capsule meetings. So what do I mean by this? Here you can see the classic PLA MNH cycle, and you can see that solutions are implemented from around the 7th meeting, which means it's usually 7 months into groups functioning where they start implementing very concrete solutions. This would mean that the family planning promoters wouldn't see a massive increase in uptake of services probably until then. So to speed this up, and as I mentioned before, in this adaptation, in this innovation, each meeting is dedicated to a problem adolescents and women face. They look at health, nutrition, skills development, and all of them are underpinned by the fact that improving sexual reproductive health will help them overcome those problems. Now, in each meeting, groups go through several of the PLA phases that traditionally would be covered by one cycle. So this means they identify, from the first meeting, they identify problems, they plan their solutions, and start implementing the solutions shortly after the meeting. This allows them to start implementing solutions, which will improve their access to sexual reproductive health services from that first problem meeting. What we considered here is the risk that in the traditional cycle, groups have more time to get to know each other, to build reciprocity, to build trust. And here, certainly the consideration is that we expect the group to take some actions literally from the second month of working together. However, we feel that the groups might start with simpler solutions that are maybe more individually based, and with time, as they get to know each other, they can start implementing more complex solutions that we'd normally see in the traditional model as well. So what are the next steps and the route to scale for this? So this pilot has started last year and is to be completed in March of 2022. Based on the pilot evaluation, the methodology will be refined by Women and Children First and MSI, and we will consider simplifying it further if needed, while at the same time making sure fidelity to the cornerstones of PLA is retained. As Mikey mentioned, that is an important criterion for a successful scale-up. Furthermore, we're very lucky to have secured funds from a donor who is happy to help embed the approach in MSI, which will make it available to all 37 countries where MSI operates. So there's great potential there, and we're looking forward to that next steps as and when we finish the pilot. Thank you very much.
Fantastic, thanks, Jo. Really great to get an update on what's happening in Ethiopia. I know it's still early stages in that particular pilot program, and we don't yet know the full potential that PLA has through a social market. But certainly the first evidence we're getting through, the first information we're getting from the first steps we've taken seem to be very positive. And thanks again, Rajkumar, for your presentation. Jo, a couple of things I just identified that came up that really resonated with me as you were talking. One was almost as one of the last things you said. It was this planning for that scale up from the very beginning, even before knowing that this is going to work with MSI. It's having those discussions and having a donor on board who's going to help to embed it and institutionalize it if it is successful. And that is clearly the route to scale with MSI, is making sure they have the funds available to make it a core methodology across all their country programs if it is successful. And that backwards planning, I know, was a big piece of work when we first set up that project. I think another thing that's really fascinating is how you talked a little bit about the iteration of this approach. So this approach wasn't just the off-the-shelf traditional PLA. There were a number of steps that have to be taken to keep changing it, keep adapting it. And again, the devil is in the detail here. We're learning all the time about the context and how that affects how PLA could work. Again, we're learning a lot about the partner and how they work, and the promoters and how they work, and even about how social markets might be able to work. And so all those things I know have helped you iterate that approach in the setting in Ethiopia. The third thing I wanted to mention was also speaking to that issue around tailoring evidence. It's knowing that we needed pilot data, that you needed to get pilot data first before you could take it to scale. That by having pilot data, you're in a better position to lobby for scale up, not just within MSI, but also across other organizations. I thought that was fascinating as well. And the last thing that really resonated was the very constraints of working through a market-based model. Is that within markets, you do have to pay a lot more attention to the due diligence and the fidelity to the model, because markets operate very differently from the public sector. And I think that's something that's, again, critical when thinking about that, and something that eyes wide open. I know you've gone into this as you've developed the approach. So thanks, Joe. Now, we've had a number of questions coming in through the Q&A. I've had some questions directly to me through chat and on the chat. I've had some questions emailed to me, and I've got my own questions. So I think we've got about 30 minutes left. So I'm going to start pulling these out and maybe put them to you two first, if that's okay, and then see if that stimulates any further questions as well. My first one, actually to you, Rajkumar, is questions come up around how you've had to adapt the traditional approach of PLA to make it scalable. So Joe mentioned how WCF has adapted the PLA approach from maternal and newborn health to SRH, and using these capsule meetings. I was wondering whether you had to do any major adaptations to the cycle of meetings or how they're run, and what those were.
Yeah, thank you, Mikey. It's really an interesting question. Two things. Adaptation and contextualization is really important when we take things to scale. So when we talk about PLA, it has gone through a series of trials. So when Ekjut trial was done, we had certain things in mind, and when the same trial was replicated with ASHA workers, so we could make some changes. For example, we could club some meetings together. Number one, we could make some meetings more interactive, and we could take some perspective from the government sides, what they think and what's best for them. Third is contextualization based on geographies. Like these meetings were tested in 2 states, and it was scaled up in a big state. So based on the different areas, we contextualize the meetings also. So contextualization do happen, and we have done this process. When we engage with National Health System Resource Center, which is one of the key policy making body, they also suggested certain things based on their experiences working with governments. So everything was taken into consideration, and it was done. And few things we kept while contextualizing that principles of participation should remain there. So the practices and principles were not been they were kept, and we always tried that these meetings do not take much time. Like one meeting happens 1 to 2 hour maximum in certain cases. So these things were kept in mind. Thanks,
Rajkumar. Really interesting. Yeah, I clearly whatever iterations you've already made, having now run it across such a large population, I'm sure there'll be further iterations down the line. PLA is not a static process. It can change and adapt as needed. So it'd be interesting to hear further on that.
Yeah, and I will add one more thing in this thing. So when I was talking here, I was talking about the scale up by government in Jharkhand, but this work also has been scaled up in another state, biggest state in India, Madhya Pradesh, where socioeconomic things are different. So more hamlets are there in some of those areas. So even the group sizes were being discussed and changed at certain places.
Fantastic. Thanks,
really,
sorry. No, that's not at all. That's really interesting. Thank you for that. I can see a question has come through from Christian Kota. Chris, hi. It's great to hear from you again. I hope you and your family are well. And this, I think, is probably applicable to both of you, I suppose from different lenses. But Chris has asked, how did we deal with the advocacy challenges, especially around collaborating with those who have high influence in advancing your policy agendas? So I suppose the question here is, a lot of scale up is actually the communications challenge and advocacy challenge with those people who can make decisions. So how have you confronted those, Rajkumar, in relation to the government, and Joe, how are you planning, or how are you confronting those in relation to working with a private provider?
Can I respond, sir?
Of course, go ahead.
Yeah, so thank you for this question. We still face challenge. It's not that challenges are over. So advocacy, when we when you give the present the impact and even at a scale thing, so you get many questions and many more things comes where you feel that okay, we need to work a lot. But definitely certain things like we believed when we started this work. We believe in one principle that always begin with end in mind. So at least one thing was there in our mind, that some parts of PLA will definitely go in the system sometimes, because community mobilization is one part where frontline health workers do, and this fits into that. So one challenge was how to fit the messaging of learnings from PLA on the existing programs kind of thing. So this was definitely there. Second, Ekjut being the organization being placed in a remote area, so presence in big meetings at national capital was tough. So and we are not being invited actually. So we were looking for even 5-minute presentation or 2-minute presentation, and we were just asking for this, and we kept on presenting, and later on when a good traction was done, we got good chances. Third point was that identifying key persons who can really influence and presenting to them. So this was done very nicely by us. We don't say that we succeeded everywhere, but we could find some persons who acted like amplifier for us also. So,
Fantastic.
so these are the key things.
Yeah, and I think that those, I'm sure, will resonate with other partners. I certainly think the determination. So it's hard work, but hard work pays off. And the idea of having those champions internally at different levels of the different structures you're trying to influence is obviously key as well. I'm sure others will relate to those. Joe, how about from your perspective in terms of advocacy with a very different partner in terms of Marie Stopes? What's been key there?
Yeah, so first for Women and Children First, it was a bit of a shift, because we would normally see an opportunity to implement PLA in a district and be really excited that we can reach so many women and children. And our main focus would be working directly with the district teams, who obviously are the experts, they know their communities best. So that would be our main contact. Starting this project, we realized that, of course, we absolutely need to work very closely with the local team, because they are the experts, but simultaneously, we're also already linking, in this case, with the headquarters in the UK, and we have a champion in the headquarters as well, so that it's not just a case of sending reports every so often to the headquarters together with the local team, but actually engaging them in discussions early on, so that they can build the ownership and understanding, and can also advise from their side on the approach. So this will be critical, because ultimately for this to be taken to scale by the organization, it will need to be housed at the headquarters. So we have a dual focus here.
Yeah, interesting. So yeah, some differences. Again, hard work, it sounds like. That's really fascinating. Joe, staying with you, there's a question from Nimala. Nimala, great to hear from you. Really great to hear from you. She thanked you for this presentation, and she said, how was the government, so in this state, the federal government of Ethiopia, how are they involved in the pilot project, or how are they involved in the pilot project?
So again, that's definitely a shift for WCF, because we always work very closely with governments. And here we have to balance it out. Luckily, MSI already have an existing close relationship with the government. So through them, we have a connection with the government. And in terms of the actual design of the intervention, even though we're not working through government facilities, the government representatives were fully involved in the design of the intervention, as well as the existing community health workers. They have been briefed on the intervention, and we make sure they're part and parcel of those conversations that are happening in the communities, so that it all fits in nicely and is not contradictory, or it's not duplicating anything what the local government is doing.
Interesting. And imagine working with a partner like Marie Stopes Reproductive Choices, who have service level agreements with government. They're working strongly with government already, makes it easier in that process. They already know how to work alongside the government and deliver services rather than work between providing parallel services. That's interesting.
Yeah, absolutely. So that, I guess that speaks also to the part of the due diligence, that we knew this type of partner. We don't have to worry about sort of building a relationship with the government, because we know our partner already has that well developed. Fascinating,
really interesting. Thank you. Looking then, another question has come in, Rajkumar, which I think is relevant to yours. Yes, it is. Someone's commented that you have 25 plus publications. You have a Trial of the Year award. You also have extensive media communication. I think it was over 200 media communications. And they were wondering what was most convincing in terms of scaling things up. Was it the evidence base, or was it the media coverage, or other things, or was it a mix of both?
So in terms of most convincing thing, the publication in high impact journals has really great value, and high-end policymakers, they do refer to it. So this is definitely the most convincing thing as per me. But to create an enabling environment around these publications is the media coverages that help. Coverages in good media publications really helps, because it goes to many other people. So access to trial papers are not with everybody, but the media's reach is to everyone. So media coverages really created that enabling environment. So it's a mixed thing, but definitely this publication in medical journals has a higher value. What I feel, and I really feel it.
Interesting. Yeah, I think that's fascinating. And this speaks to the point I made earlier, which is that the current environment around policy is around innovation. So everyone's looking for the new thing. And so the evidence base works very well, but when you have a very extensive evidence base that's been there for many years, people can start to think, well, this is no longer innovative. You published your first trial in 2010, 2011, and you're still publishing. But it's a media part maybe that keeps it fresh in people's minds, that updates it, that shows that despite the actual approach being the same, the innovations you're making in terms of how to deliver it at scale are fascinating and really fresh. So clearly a mixed communications approach will probably work best. But good to know, because I know from our perspective at WCF, we focus much more on the evidence than on the media. And that's something that we probably need to rebalance. Then I think this maybe is applicable to both, or I can make it apply to both. Someone's asked about your ASHA model, Rajkumar, and how applicable that would be to other states. So whether could it be universal across Ethiopia, in India? Could all states in India use the same model? Or do you see the need for alternative models? And you mentioned some in your presentation. You have kind of the ASHA-based model, then you have the non-governmental organization model, essentially, and then you have the Ekjut delivered model. Do you see it as being a multi-stranded approach across India, or is it something applicable? And Joe, I think the same for you. We can use that same question really to ask about the MSI model. Is that model applicable across the whole of Ethiopia in all settings where you have a market-based platform in place, or do you think other approaches will be needed? So first, Rajkumar, over to you.
Okay, thank you, Mikey. Another very good question. Actually, if you see the participatory learning and action process, it's basically a community capacity building and community mobilization process, which is structured from outside and very delicate and amenable to change from the inside. So meetings content can be tweaked, but it's very structured, and a lot of principles like adult learning approaches and respecting time of women, etc., has been taken care by this model. So in terms of community health is one key part of, when I talk in India, it's a key part of strategy, health strategy, and it fits in across the India. the question is, like when we talk about Jharkhand, where newborn mortality is high or infant mortality is high, but when you talk about the state like Kerala in India, where newborn mortality and maternal mortality is very low. So maybe when we work on newborn mortality and maternal and around maternal health issues, some of the northern states of India where these figures are high, it really fits. To the intervention, but when we go to some of the southern states with good indicators, we probably have to change the indicators, and we may have to work on, say, mental health and well-being. But this model fits. So that is one thing. Second, there is again some issues like structures in different states are different. Like this is ASHA facilitator model where ASHA facilitator is at center and ASHAs are around. So when this kind of structure is not there in other places, we either will have to advocate for another worker like ASHA facilitator, or we'll have to change the training module. But in terms of health programming, it fits. When I talk about other countries, so as part of community mobilization approach, which is really evidence-based, giving results from, right from mortality to malnutrition to communicable diseases from Bangladesh. So I think this model has a great chance that it fits into different health structures.
Thank you. That's really helpful. Go on. Go ahead.
I think so. With new evidence coming from different areas, different themes like gender-based violence or mental health, I think this model fits into areas where the burden of disease is high and mortality is high like that. So I see a good chance of fitting it. I was asking, did I answer this?
Yeah, you did. Yes, and I think before I go to you, Joe, we've just got a question in from Nita Gol, who asks, I think the question that a lot of us think when we think about community health workers, I know we've experienced it. Clearly, the community health worker structures are well placed, and particularly somewhere like India with a gold standard system like the ASHA system that's so well supported by the government. But what about overload? So did you experience any resistance from the ASHAs, Nita asks, about being overloaded with too much already to do? Were they paid extra to cover additional time or other expenses they incurred doing PLA? I think that's always critical and something that lots of people ask. It'd be good to answer that here.
Okay, so in terms of overload, whenever you talk to policymakers or senior government officials or senior officers from any department, they will always say that overload, and they are right also. The crux is into create something which the facilitators or ASAs who don't find it overload. So when they come and see the meetings, when they visit to the field areas where these meetings are happening, so they got this they get the response of this question. I just forgot, what was your second point of the question?
Do they receive any additional incentives or anything to cover the additional piece that is involved in PLA?
Yeah. And in terms of incentives, ASHA workers across India, they are the incentivized workers. They are not on the fixed monthly payment system. So every work, they get some or other incentive for it. And it was easier for us to create a small incentive for them from the government system. It does not increase their budget, very high when they compare it with the benefit they get. So having a structure of incentivized worker really helped. And we were getting a lot of suggestions that this work should be volunteer. It should be they should not get any money. They should volunteer to work. And principally, as an organization, we believe that if we cannot volunteer our time and we charge money, how come we can ask the front line, the most lowest level worker to volunteer? So we always looked for and we always advocated for incentives, and luckily we got it. Third was, incentive is there, timely disbursements are important. And here the top leadership's role comes. In the state of Jharkhand, the principal secretary health, who is the head of the department, he took this initiative. And after around one and a half year, these incentives were regularized, and it also worked as motivation. When you get you paid for the work. So
Really interesting. Thank you. And thank you for answering that follow-up question. And now, Joe, bringing you back to the original question, which was around the applicability of this model across Ethiopia or to other settings. It'd be interesting to hear your response to that.
So what I...
Yeah. Oh, sorry. Passing on over to Joe a second, Rajkumar.
Yeah, it's Joe. It's me or Joe?
It's Joe, this one.
Yeah, so I think applicability of this model, once we pilot test it and see what benefit it brings, it should definitely be applicable to other parts of Ethiopia and other countries that have a social enterprise model. As Rajkumar mentioned, this is just a tool for community mobilization. So as long as the social enterprise already has some community presence or wants to build demand in the communities, PLA should absolutely be applicable to this. And I think from the wealth of experience that comes from all the partners on PLA, we have a pretty good approach. We have a pretty good idea of when PLA will work and where it won't work. So after some work and some adaptations and considerations, we know what questions to ask, what metrics we need, and then we can advise whether the PLA will be the best option. But in terms of the approach and how it works, it should be applicable in most contexts, yes.
Interesting. Thanks, Joe. I've seen a comment. I'll leave the coronavirus comment to the end because it's always nice to end the meeting with coronavirus. I saw just a comment from Karen Hampson from FRI. Karen, thanks so much for joining. She's really interested in the work in Ethiopia, Joe, and it would be great to see how radio could support this kind of initiative and also contribute to scaling up through listening groups or similar. I suppose I can quickly just respond to that comment, and that this adaptation that you've been doing in Ethiopia has been adapted with the kind of thought in mind that could also be applicable to radio. And you maybe can just do a couple of minutes, maybe explaining, Joe, what the next pilot program is that you'll be delivering around radio.
Yes, absolutely. We had to balance here in the presentation that we're talking about bringing this to scale versus just on the innovation of this adaptation, but we're very happy to send more materials around how this PLA in capsules work. But speaking about this specifically, yes, indeed, the capsule approach has many benefits that we hope will have many benefits that we mentioned, but also one of them is this modular form of delivering PLA meetings, where in each meeting groups discuss problems, come up with solutions and start implementing them. Means that groups don't have to attend the whole cycle. They don't have to attend the whole 11 meetings over 11 months. They can come in and out and still benefit from each meeting. This means that a project that we're hoping to start soon with colleagues from FRI is exactly using radio to deliver PLA meetings. Those meetings wouldn't have the facilitator that we're most familiar with, a person who is well trained and then make sure the groups comes together. This would then rely on having an interesting radio show and a group committee that would ensure that people do come together. So to make it adaptable to radio, we had to make sure that there won't be a person who will make sure everyone comes together for the meeting, that some people might come in and out, might not be able to join every meeting. So that's one of the critical points to pilot PLA through radio. And I'm sure we'll be able to do a community of practice on that topic later on once we start working on it.
That's a good idea. Thanks, Joe. I'm seeing Rajkumar. There are a couple of questions here for you, if that's okay. One, I think probably easy to answer, from Khadija. Khadija, howdy body, good to hear from you. She asks, could you please clarify the roles of the national health workers and the PLA facilitators? Are the facilitators enrolled from the national health program? So I think her question is here about, are the facilitators as ASHES, are they enrolled by the national health program? Which hopefully is a nice, easy one to answer.
Okay, sure. So the national health worker, I'm talking with the ASHA workers, which are the frontline workers, and every village has one ASHA, and they are incentivized workers. Their role, they have been given many roles, like they aware people on many health issues. They accompany women in labor for delivery to the hospitals for institutional deliveries. And they also have some works on malnutrition. They support the auxiliary nurses, midwives, and the health system in immunization. So they have multiple roles built around health and nutrition. So
That's great. Yeah, and I think answering a question, that those primary healthcare workers, that cadre of workers is employed by the government, and you train them, you skill them to do PLA, but they're still employed directly from the government, not by yourself as a partner. And
on the balancing part, they are trained in many health modules. So over the time, these workers came into existence from 2005 in India with the rollout of National Health Mission. And by 2008 to 10, almost 800,000 ASHA workers are placed in India. So they have undergone many trainings on health aspects. So we have to train them on processes. So PLA is all about processes. Yeah. So they have good understanding of health, and it helps.
Yeah, and I think that leads directly into another question from Christian Kota in Malawi. He likes the job training approach, your sort of odd, even, on-the-job training approach. And it's clearly so innovative. It's got great value for money, he says, enhanced ownership and sustainability, as well as the power of ripple effect created through residual impact. But his question is, how are you able to balance this without compromising quality? So essentially, how can you use that system and maintain fidelity, which I think speaks to your point about PLA being process-based. So it'd be great to get your thoughts on that.
So this is another interesting question, and this question we were facing to ourselves when we were starting the scaling up, and our main doubt was how to maintain the quality both at the training as well as at the meeting level. So we came up with very small checklists to see whether participatory processes are being applied during training or not, whether these trainings are interactive or not. So we have a very specific 8 to 10 point checklist. So we keep doing that, number one. Number two, so we trained the national and state level trainers from the National Health Mission. And in these trainings, at least one of the trainers was from Ekjut. So we were ensuring that